Kenya has some of the best healthcare policies. We don't have a challenge with policies. Our problem is in implementing these policies. A lot has changed because now youth have access to digital technology. So getting to the youth, we have to go to where they are. And a lot of this information now is passed on digitally. We focus on the person, on the individual and the people to ensure that there's access to services for these particular people.
My name is Rachael, Mwikali. Welcome to today's episode of Gender Equality and Human Rights podcast. And I'm happy to be joined by a sister, an inspirator who works in the same field like ourselves. And I'd like you to introduce yourself, say who you are and what you do.
Thank you so much, Rachael. My name is Dr. Margaret Njenga, and I work as the CEO of Population Services Kenya. Population Services Kenya is a women-led organization that focuses on improving the lives of Kenyans. And we work very closely with the government of Kenya, with development partners like the Denmark Embassy in Nairobi, to work towards reducing matters to do with gender-based violence. And PS Kenya is funded by the Embassy of Denmark in Nairobi under the Accelerate program. The Accelerate program works in 13 underserved counties towards reducing, we work towards 3 zeros. Reducing maternal mortality, ensuring that no mother is dying while giving birth, reducing gender-based violence, and ending harmful traditional practices, which is very key in our country, and also increasing access to contraception. Family planning. So that's the work that we do in healthcare, working towards ensuring that Kenyans and women are not being left behind. So I'm really excited to be here with you, Rachael, a friend for many years. Yeah. And also I really admire the work that you do and the courage to really go out there and serve this country.
Thank you, Dr. Margaret. And I prefer like now calling you Maggie to avoid this looking more professional. However, I respect everything you do. So, Dr. Margaret, I really wanted to know from yourself and your background, how did you start doing this work?
Yeah, so my background is in healthcare, and I studied medicine at the University of Nairobi. Thereafter, I really wanted to practice and work to help Kenyans or to help people who are sick to get better. And I worked in Nakuru County Hospital. Then it was the provincial referral hospital. And while there, just as an intern, I saw the challenges in our healthcare system. Women would come to deliver, but we didn't have supplies to support these women. For example, you'd find that a woman would require an emergency cesarean section, but the theater is not working, or there is no clean linen. And just for that one reason, you refer the mother, and the next facility would have to be perhaps even Nairobi, which was such a long distance. And that really broke my heart, because Nakuru, where I was working, was a referral facility. This is where many people, women, were coming to get healthcare services, but they were not getting it because of the failure in our healthcare system. So just seeing the challenges, lack of supplies, high turnover of healthcare workers, I felt that working at that level would not enable me to bring the change that I want to see, because naturally I'm very solutions oriented. And so I sought to bring change at a higher level. And that's when now I landed in work to do with policies and working at the national level to ensure that the country has strong policies. And while at the policy space, again, the challenges were even greater, because I realized Kenya has some of the best healthcare policies. We don't have a challenge with policies. Our problem is in implementing these policies. People know what should be done, the leaders. And our culture really is rotten to the core. Because the leaders in government who should be bringing change, all they look out for is for myself. What do I want for my family? Instead of really caring for your community, the next generation, and the generation even after that. The government really should be providing those services for everybody. It's not just about your family or the people around you. It's about the entire community, where the leaders should be working towards seeing that. And you've seen many leaders, when they fall sick, They fly out of the country, yes, to get healthcare services. Yet they are the ones who should be ensuring that our systems are working, that there's enough resources going towards healthcare systems, and that there are healthcare workers who are there, there's medicine, if there are tests that needs to be done. And I'm sure each of us can really tell that story of where they know somebody who got diagnosed with something, the family couldn't pay, the public facility didn't have the resources, they had to go to a private facility, they couldn't afford, they sold some of their property. And unfortunately, the person ended up dying, and very close family member. So each of us really, we have that story of the pain we have felt because of our healthcare system, and it's very, very, very painful. So after doing all that, I figured, why don't we move to prevention? You know, prevention now is better than cure, because we know that the healthcare system is broken. Are there things we can do to prevent people from getting to the treatment side? So that's really what drives me. If there are things we can do, like for example, even our conversation today on sexual reproductive health and rights, if there's something we can do to prevent, like for example, teenage girls from getting pregnant, let's educate them. Let's talk to them. Let's tell them that you have a bright future ahead. Let's talk to them and ask them, what do you think? What plan do you have for your life? And you'll be surprised. Some of the programs that we do, we speak to teenage girls and they say, you know, you're the first person to ask me. I'd never thought of what I want to be in my life. That's a 12, 13-year-old girl. And in some counties, like for example, Kilifi County, where the Accelerate program funded by the Denmark Embassy in Nairobi works, we speak to teenage girls in that county just to give them that light of hope, working directly or having the conversations with them. There's child marriages in this country where you're seeing child marriage is accepted in some communities, and these are retrogressive cultural practices. And in the same community, they don't want the teenage girls to get contraceptives. It's really an oxymoron.
Even comprehensive sex education.
Exactly.
Because that has also been like the fight around, when you talk about SRHR, sexual reproductive health and rights struggle or advocacy in Kenya, the same, even people the rights duty bearers that we're talking about, they refuse. Exactly. In terms of prevention, to have comprehensive sex education in schools. Yeah,
exactly, yes. And when you look at education, it's giving people knowledge, because knowledge is power. We want them to know that these are the options. This is what is available in the public facilities. You can get these services. You just need to know. And the choice really is left to the individual. So essentially, that's a lot of the work that we are doing to educate communities, educate people, and especially in the most rural, most marginalized communities, which are really left behind, because we are seeing the gap between the haves and the have-nots really grow. And right now it's much worse because of the economic situation. There's high levels of unemployment, inflation. There's a lot of pain in many households. So the work that we are doing in PS Kenya is really to prevent as much as possible. Whatever can be prevented, let's do it. And we don't do that alone. We do it with the other civil society organizations and grassroots organizations, community-based organizations, like in the 13 counties under the Accelerate program. We work with community-based organizations to ensure that, to support, so that change is led at the grassroots level. We want the people to have the power.
You know, when I'm listening to you, Dr. Margaret, it takes me back even to the work that through even the role we have at the Danida as YSB, and you interacting with your organization and through your leadership of on SRHR, that we still are struggling. We still are doing so much work. However, we are seeing the new phase of religious fundamentalists or anti-rights, anti-choice group being well-resourced, coming to, I'll say, suspend the gains that we've been able to do. So from your own perspective and looking at the ICPD achievement and milestone, what are the key challenges that you see these are the things as an individual, as an institution, that we need to focus in ensuring that we don't lose the game.
Yeah. So just riding on the ICPD. ICPD is the International Conference for Population and Development. And right now we're talking about ICPD 25, where Kenya again recommitted towards advancing the issues that were discussed at that particular conference. And the conference really worked, or rather worked towards advancing matters to do with women empowerment and human rights issues. So that really ties into moving this country forward. So Kenya, we've made progress, I'd want to say. So let's start by celebrating that. We are seeing now more women.
And we also hosted the conference.
Exactly.
Was it in 2019?
Yes.
Maybe also you can say a bit on the conference.
Yes. Yeah. So the conference was held in Nairobi, and from that conference, Kenya again recommitted and signed and said we are going to promote these 19 commitments towards advancing the ICPD agenda. And for Kenya, and especially the work that we are doing under the Accelerate program, we focus on 3 commitments. And the 3 commitments that we focus on is aligned to the work that is done by the Accelerate program funded by the Embassy of Denmark in Nairobi. And this is to advance matters to do with ending gender-based violence, where we are working towards the three zeros: gender-based violence and zero gender-based violence and harmful traditional practices, zero maternal mortality, and also zero unmet need for contraception. So those are the 3 commitments that we are working on, as much as the other 19 commitments. So there are other partners who are really tracking on the other commitments that this country has made. So that progress has been there. We are seeing there's an increase in contraceptive prevalence rate, where in some counties that has gone up. And even as that goes up, there are other multiple issues that are really...
Has it gone up in terms of intake or in terms of not being
first of all, awareness.
Yeah.
More people are aware about the need for contraception, and also the uptake. The systems have improved in comparison to before, where we had longer stockouts of contraceptives. Right now it's better, but we are still not at the ideal because getting contraception is not something that would take girls or women to a facility easily. Yeah. Therefore, when a girl comes to a facility to ask for a contraceptive and they don't get it, that's a big missed opportunity because it's unlikely that they'll come back. Also, how they felt by getting there, and the product was really missing. And we don't know where this will end up, because you'd find maybe this girl has 3 or 4 other children, and just by missing that contraceptive, that may make her again get another child that she might not be prepared to take care of. And to correct, just to your question on the gaps that are there, I think this issue, like to do with contraceptives,
and even family planning, because I feel they're kind of the narrative people most of us are confused to know the difference between contraceptive and family planning. So I think if you can help us, for the public or the viewers, to understand that it's, yes, the same method, but different ways of definition.
Exactly. Yeah. So even just by the term family planning, it's a very old term that's associated with, much older women, now maybe some who are in their 70s or 80s. Therefore, the younger people don't even want to use that particular term. But it's actually about spacing your pregnancy, healthy timing and spacing of pregnancies. And here we are looking at when a girl is born, they go through their childhood, then teenagehood. I mean, these are very normal stages of life. This is life. And let's take life as it is. When a girl reaches her reproductive age, she's ready now to give birth, and really that's also a calling for women to reproduce and really work towards supporting the work that they're doing and all that. So just going through that, all those life stages, when a woman gives birth, let's say the first time, they need time for their body to recover. They need time to breastfeed their child, because exclusive breastfeeding for children for the first 6 months has really been proven towards helping children live longer. Child mortality goes down just because of that, just exclusive breastfeeding. The woman will be able to take care of this child until the child is able to feed better. She can also now go back to taking care of herself so that she can be stronger to take better care of her family. Her partner also will have enough time to make some income so that that income can support the household. So really it's about that spacing for health reasons so that the woman can recover, for mental reasons, for the family, and so that there's some ideal space before the next child is born and the next and the next. So family planning is not really about controlling population. And that has been a very big myth.
Narrative.
Yes.
By anti-rights, anti-gender groups.
Exactly. The minute you hear family planning, people say that it's the West who are now giving contraceptives to Africans so that they cannot, they don't become too many. It's about controlling them. That's not the issue. The issue really at the core is so that this particular household, at the nuclear level, the woman can recover, the man can be economically stable to take care of that household. The child can also grow in a loving home. And the society, because the society is a reflection of the nuclear families, the entire society can thrive just by taking care of this particular household and all of them, then the society becomes a better place for all of us. Also, it's also a planning issue and development, because as a country, you cannot plan for your people if you don't know how they are reproducing. And by planning, what I mean is that there's enough schools for education, healthcare, you're able to take care of these particular children, you have enough resources in your budget to take care of your population. In some countries that are more developed, people are paid just for being alive. But in Kenya, we really have a long way, very long way to go.
I would really love to hear from your own experience. How many youths, in terms of also the targets that you receive, go to public hospital to get just advice on contraceptive and not family planning?
Yeah, a lot has changed because
and
now,
how friendly are the clinics?
Exactly, that's a very good question. A lot has changed because now youth have access to digital technology. So getting to the youth, we have to go to where they are. And a lot of this information now is passed on digitally through them, the apps that they are on, the sites that they are on, and there are very clear chatbots where they can have conversations in a safe place. Because what's important to this youth also is dignity, also time, because they need things to move very fast. So it's very rare to see a young person just walk in to ask for advice in a public facility on sexual reproductive health. They've already had that from peers, next, either the people they go to school with or in their community. So that information is already at that grassroots level. And that really informs how we target these youth, because we have to co-create with them and work with them, listen to them, so that we can reach them wherever they are and solve the problem that we are working towards solving. When they get to the clinic, some of the things that we really advance is training of healthcare workers, number one, so that they can value clarification and attitude transformation, which is very crucial, so that these healthcare workers know that they are there to provide a service. Whatever values they have, put that aside. And attitude transformation, so that if they have retrogressive values, again, they put that aside so that they can focus on the service that this particular adolescent has come to seek in that facility and provide that service in a very professional manner based on evidence that has shown access to services for these youth. Counseling is also very important. Of course, number one, we advise the youth to abstain. That's very, very crucial.
Is it workable?
It's not.
Yes. Because that's also, like, for me, I'm a bit skeptical as someone also who does like SRHR activism. We are dealing with what you're saying. Now, this is where contradiction comes. The policy versus the law. Where we know clearly with the zero like ensuring that you end all this kind of violence that are targeting different constituency. We want to ensure that they have the information. We prevent, let's say, HIV, we prevent GPV, we prevent even like unsafe abortion. Yes. But at the same time, I'm sexually active and you're telling me to abstain. Does it work?
If you do that, you're going to lose these adolescents or these young people because they'll continue with their practices, yet there are tools and there are methods that are available for them to plan and live their lives as they desire. And these are very natural things, and very human things. So it's really about having the conversations with them, meeting them where they are, letting them know these are the options that are available, pick what works for you. Essentially, giving the power to the people. And some of the work that we also do is working with religious leaders who understand these issues because they deal with people, they deal with their congregation who know, who have accessed or who have experienced the impact of teenage pregnancies in their own homes. They've seen how it has curtailed the life of these either young girls so that they're not able to really live their lives to the fullest potential. So they get it. So working with such religious leaders, even imams, they are very progressive imams who promote and know that it's important for women to have a choice and use the services that are available, that is provided by the government. But some of the gaps that we are seeing in the work that we do has to do with data. We don't have enough information to know how big this particular problem is because of stigma. Number one, stigma in access to healthcare services, sexual reproductive healthcare services for young people. There's a lot of stigma for them just walking to the facilities. So that's a missed opportunity. For those who come, recording that information, even the healthcare worker doesn't want to record because they'd be seen to be offering services to young people. And culture as well. These are things that are shunned and looked down upon in our society. So this issue of data really is a big problem. And to move it further to other communities, like for example, persons with disability, gender diverse people, the gap could be even bigger. The data that we have is not enough because this data is not easily recorded. So some of the work that the Accelerate program has done is to support at policy level, supporting the government to have the tools and training now at facility level, training healthcare workers so that they are able to key in this data. Like for example, if a person with disability comes to access contraceptive services, that's recorded. But it's been a struggle because we work only in 13 counties. The problem is bigger even in 47 counties.
So Dr. Margaret, it makes me also now want to move from now the service to also like policy and law. Like you know, I'm also one of the first petitioner for the RH policy, which also I want you maybe, if you're okay to explain just to the viewers where the policy contradicts the law. With RH policy, you saw that let's say Article 26(4) says you can have an abortion, let's say in the hands of a professional doctor. But when it comes to RH policy, it criminalizes abortion. When it comes to RH policy, which was passed by the Kenyan government that made us now go to court, it's very clear to say that you cannot access contraceptive or family planning when you are less than 21 years, which contradicts the Constitution of Kenya. When you are above 18, you are an adult. However, also we acknowledge they are teenage mothers. So why this contradiction? That we have the law, which is very clear, you can access services, whether you are a Kenyan and Kenyan in the land of Kenya, where else we're having these people in the ministry who are pushing also a policy that is against the work that you are advancing or I'm advancing or the Constitution is advancing. How do you balance that also from your own professionalism? Because also you have seen doctors being arrested in this country for helping girls who have been raped also to procure abortion or to get even contraceptive. So how do we balance this contradiction of the law and the policy?
The matter to do with the RH policy is very thorny. And that's not an area that I would want to touch on deeply. So I'll touch on the component that we are working on and really what we are doing to curb this, because we work in an ecosystem and this ecosystem must be respected. And we must, because this is a country that's heavily religious, the Christian population, Muslims, all that. And that contradiction has been there for years. Yeah? So what we do, just to curb this, we focus on the person, on the individual and the people to ensure that there's access to services for these particular people. For example, if you're looking at an individual who's gender diverse, when they show up at a healthcare facility, that should not be an issue at all, because this is somebody who's come to seek healthcare services, and whatever services they desire, for example, if it's HIV prevention, that service should be offered. If it's somebody who's come for gender-based, a survivor of gender-based violence, that service must be provided. And what we really base our work on is on the Constitution in healthcare, access to healthcare services. So by taking that channel and as a rights issue of access to quality healthcare services, that's the work that we are doing. Because the other issue, it's much bigger. And it's very intertwined. So just how do we lessen the burden? It's by ensuring that should this person show up in a facility, they need to receive the healthcare service that they need. And also awareness level, training of healthcare workers so that they know the value, clarification, and attitude transformation, that you must provide these healthcare services to the highest quality possible. You took an oath for provision of healthcare services. So do stick to that in alignment with your profession. That way, we lessen the burden and we don't see many people being turned away because of lack of access to healthcare services. So it's a very tricky balance working in this space and ensure. And again, that's also another area where data, we don't have enough data to support that,
As an evidence.
As evidence, exactly,
So I want to come back now to our current lived realities on the state of health in Kenya. We are seeing shift, share, and everything. We acknowledge also, like according to Abuja Declaration, countries are in not less than 15%, And there is a crisis in Kenya, like you mentioned. A lot of families are going bankrupt because of the status of their health. People are paying so much, not getting enough services. Where do we see ourselves? Cutting of USAID. We have seen community health promoters now not having enough support. We have seen close out of drop-in centers, even let's say for sex workers, for community places where people will go to get their ARVs. We have seen condoms stock out. So where are we? And how do we navigate around this crisis that we don't know where we are going? Geopolitics affecting local. What do we need to step up to our government? Because also we are paying tax.
So the Abuja Declaration, one of the commitments that Kenya made is that 15% of the resources of this country would go towards healthcare. But consistently, we have been way below that. In some counties that are progressive, you'd find they're at maybe 10%, which is quite rare. And most of that, within that amount of money, it goes towards paying healthcare workers. So essentially, we've not solved the problem because we are dealing with healthcare service delivery, more of recurrent expenditure as opposed to development. So you'll find the healthcare workers, but they don't have the supplies. So what are we really doing to our system? Because even if the healthcare worker shows up, they don't have proper equipment, simple things like gloves. If they don't have that, they ask patients to buy gloves. It's very, very sad. Because these patients, some don't have the money, and for those who have, if they're buying gloves, then next they'll buy the medicine. It's just too expensive on that. So as a country, and what we've currently seen is that development partners are now cutting down. Governments are shutting down aid because also of the abuse of some of the aid resources at whichever levels, whether it's the global level, whichever levels, there could have been some wastage in the system. There's also what we are seeing with aid is that there's a very strong downward trend, which really is a wake-up call to us as the Kenyan government at all levels, at the national level, at within the 47 counties, that resources towards healthcare allocation need to increase. Yeah. Nobody is coming to save us as Kenyans. We must step up. And by saying that, since nobody is coming to save us, even us as our own people, we must understand our budgets, we must understand where our resources are going towards. We need to know the commitments that we have made as a country, 15% of resources to be allocated towards healthcare. We are paying taxes, we are overtaxed.
Yes.
And there's a shift in all this healthcare system from NHIF to SHIF. It's something that as Kenyans we need to pay more attention to and hold the government accountable. So the power is really with the people. It's with the people understanding where the problem is, where the money is going, and holding the government accountable. For example, working with your, just to make it a bit practical, working with your MCA, if your local health facility, health center does not have gloves, those are things that should be raised with the MCA so that the MCA can also escalate that within the county government and ask the government to allocate more resources towards healthcare. If your local health facility does not have a nurse, depending on the level, or if there are tests that cannot be done there, those are things that we need to start asking very tough questions as Kenyans. And holding our government accountable. Why? The next county, like Makueni County, might have medicine. How come we don't have this in our county? So just asking those questions is very crucial so that now the leaders, and also the kind of leaders that we elect, we need to shift and elect leaders who we know we can actually hold accountable, people we can really work with and support them to deliver. I think the health system is affected by everything.
Yeah, the ecosystem.
Everything.
Because the way you are saying,
ecosystem. Yes.
When people are saying USAID is closing, I was like, yo, because even us, one of our partners is Wellspring Philanthropic Fund, and they closed before USAID. They said they gave news you're going to close, and you know they're the biggest financier for health, and even SRHR, now USAID. And now government now trying, the way you're saying, stealing money and not providing to the citizen. And we're heading to elections. So how does the future looks like for health? Does it mean, how does the future looks like for healthcare providers? We have seen criminalization of healthcare providers. Even as a country, from you being a doctor and also being within the same space of health, what are the things that you'd recommend for us even to stand in solidarity with doctors? We saw even during the protests and how they came through big time for the constituencies, for the Kenyans. So what are these things that you think even as a country, as much as we are pushing from the service provider, but also to the people who give us service, how do we need also to stand with them?
I think it's about getting involved in local conversations. You know that most of these meetings, at least in Nairobi, the city where I live, happen over the weekends, maybe on Saturday or Sunday. And when you're called for those meetings, it's important to show up. Show up for the community conversations. If they have, for those that happen on weekdays, those who are available, it's very important to be part of these conversations. And while standing in solidarity with the healthcare workers, is also listening to the healthcare workers. What's their story? Because these healthcare workers, most of them are criminalized because they are told, you know, you didn't show up at work, without understanding this particular healthcare worker. Why are they not showing up? Because when they show up, they're medical workers, healthcare workers, they're human beings too. When they show up, they are the face of the government at that particular time. So they see the pain of the people, what they are going through. Therefore, you can imagine every day you wake up to go to work. And when you get to work, people are bringing you problems. They bring you problems. You can't solve those problems. What do you do? What do you do? Even if you show up, you know what's going to come. They'll come, tell you, this is the challenge that I have, whatever issue they may have. You tell them, this is what you need to do. Here's your prescription. These are the tests you need to run. But you know the lab is not working. You know the pharmacy is not working. So essentially, it's a zero-sum game. Unless we fix the system, then it will be a problem. So some of the things that community members can do is understand these healthcare workers. Don't be quick to criminalize and say they are not coming, they missed duty. But why? Why are they doing that? You'll be surprised at the passion that many healthcare workers have. It's a calling. Most of the people who are still working in government health facilities, it's a calling. They truly love what they do. But there are some things you can't do, work or deliver beyond, because the system does not support you to do that. So just, being and inviting them even to be part of those conversations and defending them and listening to them. So I think it's for us as a community really to listen to each other and be truthful to ourselves.
Dr. Margaret, there's this one thing I realized as working within the sector, something called patient charter. Which I don't think many people or viewers know. There's this document that exists to protect even patient. Yes. Could you please maybe elaborate to us, what does this charter say about patients, so that we remove this narrative that, oh, we can't trust our public doctors, they're not confidential, or even sometimes you have seen patient being detained in hospital, which is not okay. So would you please just elaborate about the patient charter to just tell the public? You have this document that protects you, and that's why it's important for all of us to invest in our public hospital or even around the work on right to health.
Exactly, So the patient charter is an agreement, and the patient charter is really what guides or tells you as a patient what services, what are your rights, what will you get when you come to this particular facility. And you'll see in many public facilities, they have this put up on the walls, right outside. Before you enter the facility, you'll see it's been written, consultation time, maybe 10 minutes, waiting time. So it's very clear on what they should expect when they walk onto that facility. It's very nice in many facilities, put up out there on the walls, even in very rural areas, clearly written. You'll wait for 10 minutes, and the next thing you'll be seen by a nurse, triage, maybe another 15 minutes, you'll be seen by a doctor, another 20 minutes. So the time you'd take getting your medicine and all that, if you have tests, that will take roughly 20 minutes. So the time you'll take in this facility maybe is 1 to 2 hours, just for the patient to understand what to expect, because sometimes you may think, I'll just walk in and out. That patient charter really speaks a lot of goodwill of what that particular facility seeks to serve or seeks to offer the patients, the people who are walking in to receive services. That's a very powerful thing, because, and many of these facilities you'll find they have their vision, their mission right out there on their walls in very rural areas, very colorful, beautiful walls, so that they know that this is what this facility is going to give me. So there is whatever is there on policy, but the practice, that's where the challenge comes in for a number of reasons. There could be a shortage of healthcare workers, so the waiting time might be much longer. There could be, or sometimes the healthcare worker is not even there at all. The facility has been shut because maybe a healthcare worker has not been posted by the government. And those are the things really to look out for and to hold our leaders, the MCAs, and also like the facility, within every facility there's a committee that sits, and these are some of the things that we could support them and understand what are the gaps towards delivery or supporting this facility to deliver as you've desired in your patient charter. And most of them will tell you the issue is to do with the resources. Either money is not sufficient, there's also supplies, some medicine could be lacking, lab, there could be lack of reagents. But then there's just that goodwill really speaks a lot, because people would know that the facility wants to deliver this, but there could be many other challenges. And it's a step really in the right direction.
And I think an investment that maybe also, because also you work with government, and from me being a big fan of your work and many other Kenyans, is that where I feel also based on the patient charter, that is a gap, is around also value clarifications and attitude.
Yes.
Because young people, to be honest, you're like, you go, you're like contraceptive, condom, or I feel I want to be tested, STI or STDs, but the person's like, even you having sex, or they just rubbish you, like, they are like, you can't access. And I think these are the things also, like, from your own investment, government needs to learn a lot from CSO now to implement in most of these tools and strategies that can be able to sustain even us believing in our own healthcare facility.
Exactly.
So now I want to take you now to the fun part also. If today you're the Minister of Health, today, which is possible, what are the priorities? If now we look also based on SDGs, Sustainable Development Goals, which we see health falling, SDG 3 on good health and well-being, and then SDG 5, what you talked about, gender equality, whether it ensures from women representation, also like ending GBV. We have seen also cases of femicide increasing in the country. If today you become the minister, or you're the one who was giving advice to the president, what would be your top 3 priority to put in resources or to prioritize as the minister as part of your legacy?
Yeah, super. That's an excellent question. Number 1, back to the Abuja Declaration, 15% of allocation of resources towards healthcare. Kenya has the resources, but wherever it goes, that's where the biggest challenge and the biggest opportunity lies within healthcare. So after prioritizing the Abuja Declaration and resources are put in place, then we now move to the healthcare system, because now the healthcare system is very well resourced. Number 1, the system is run by people. Therefore, you must have the right people in the right places. That's crucial. So it's about letting the system work.
Why do you mean the right people in the right places?
The right people in the right places means that there are some positions in this country, in healthcare, that really need to be led by the right people. By the right people, what I mean is people who are qualified and are able, experienced, and have the passion to serve and are able to deliver within their particular roles. Because remember, it's not about an individual, it's about a system. And by the system, I mean across all levels. At the national level, the different departments of health, there's also at the county level, there's the health at the governance level, at county level, and also health in delivery at the facilities. So ensuring that we are meeting the WHO, the World Health Organization standards for resourcing the healthcare system, and sticking to the ratios per healthcare worker, what number of patients they would be able to see. So sticking to that and having the right people in the right places. Therefore, if you need to have a health minister, there would be. At county level, you have the right person, somebody possibly who has the passion to lead in healthcare or who has served in that healthcare system, somebody who understands the challenges in that particular system. So after the people cannot deliver without having the right resources. Supplies, and by supplies here we have the medicine. It's very crucial that they have these particular products for delivering or for working or for delivering on their healthcare services. So the medicine and also the diagnostic things like labs, because when you don't have the right diagnosis, you can't give the right treatment. You'll just keep going round, and eventually the patient may pass away even before you get the right diagnosis. So this is really a systems issue. And by supply here, we are looking at supply chain across all levels, right from KEMSA and getting that even to the facilities. It's very crucial to have that. We already have some systems in place for data. We need evidence so that we can know if these measures that have been put in place are working or not. So that feedback loop of evidence, data being generated by the system from the facilities upwards, and that data being consumed by the policy makers, by the leaders at county level. So at each particular unit, even in a healthcare facility, whatever activities they put in place, let's say if they are looking towards reducing the number of women who are dying, zero mortality, and they have put some interventions in place, they need to see the data that's coming in. Is our intervention working or is it not? That's very crucial. So this data is not being utilized just at the top level, but it's being utilized in every center. based on the problems in that particular area. If it's low immunization level, they've put vaccines in place and now working towards ensuring that every child is vaccinated. So again, the data, what data is coming in? Are children being vaccinated? And if they are being vaccinated, then why are we seeing more cases of, let's say, diarrhea coming to the facility? It means, so really consuming that data is very crucial. So it's more of a systemic approach. Policies, we have policies in place.
We don't need
so
more
that's
policy.
not, that's not a
Also
priority.
we have the law in place.
Exactly.
Yeah.
Yeah. So it's the people and ensuring we have enough supplies for the diagnosis and also for the treatment. That's
And
very
the right leadership.
excellent.
Yeah.
Governance and leadership is a
We need that,
big
especially
deal.
now in
Right
Kenya.
people. Yes.
We need that.
Yeah.
So I'm coming back now as we close out. I want to hear, like, beyond just the person, the idea, the leadership, there's an individual
Yes.
called Margaret
Yes.
or Maggie. This work is also, we know it's brutal. It's not easy when it comes to fundraising, which also it gave us a few tips. But also just meeting all these cases of being frustrated when the system are not working. You said you moved from public to now civil society. We have seen people moving from civil society to public, or vice versa, the other way around. What is your self-care routine, as people say self-care, or rejuvenating routine? What do you do for fun?
That's a good question.
Yeah. Because I know there's the fun part apart from serious about you, Maggie.
It's true.
Yeah.
And without that, I can tell you I wouldn't be here, because the work that I do in a non-profit, in civil society, and many other people like yourself, Rachel, this work is hard.
Yeah.
So just by realizing that it's hard, because sometimes you could be working, you think you're the problem. So it's important to recognize first that the work you're doing is hard. And you're working towards changing a system. And this system has people, which is very difficult work. It's not like working, not to demean any job, but it's not like working in a bank where either money is coming in, you're counting, and something like that, and you're able to see results much faster. Here, the work that we do takes years before we see change. We may not be here to reap the fruits of the work that we are doing. So we must be cognizant of that. That's very important. And after
So what do you do?
realizing that is taking a break. When things are not moving, you take a break. So what I do as I take my break, I do a lot of exercise. So walking is my thing. I walk a lot, and also I swim. So those two things. And also socially, because that's physical. Mental health is also crucial. It's not just about the physical health. Well-being, the mental health, I chat, I talk to people just to get a good feel of reality, look for friends, laugh. Laughter is crucial. Therefore, that laughing really gives me a lot of peace, and having a good sense of humor, knowing that, I've done this, this is what happened, and these were the factors why it worked, this is why it didn't work, and celebrating success, no matter how small, we must celebrate that.
Wow, that's so inspiring. And I know a lot of young people, including myself, you inspire us a lot, and you're going to be inspired as we watch this podcast. There's one aspect that I would not want to leave you, because you're a resource. I know there are a lot of grassroots organizations or young women who are also looking up to you, are doing the same work as you, and they're struggling with fundraising. What are some of the tips that you can share with them in terms of resourcing for the movement, or even having a governance structure that can help them to attract resources? And just even sustaining organizations.
True.
Like maybe 3 of them, tips that you can tell them, if you need to be successful in this, it's not like the 100%, but for me, as Dr. Maggie, I've managed to do this because of 1, 2, or 3.
Yeah.
Yeah.
Fundraising, number one, realizing it's a difficult job. Therefore, you have to be strategic so that you don't burn out, and you don't keep chasing the wrong leads. Therefore, you need to know when to say no. That's very important. Yeah, knowing when to say I can't. Yeah, sometimes, yes, because some organizations have been used towards channeling resources for the wrong reasons. And sometimes you're given resources that are too little, but they demand too much. And I've seen many organizations take money, yet they cannot be able to deliver. And that really hurts your brand and affects you. But the biggest tip, over my, I think, 18 years in fundraising, the biggest thing that I have seen yields is having the right networks. People fund people. People fund people they like. People fund people they know. And that really helps. And I think that's where most organizations may not prioritize because you may think it's because of other factors, either you have not put your governance structure in place. All these are important, organization policies, but it's also about knowing the right people in the embassies, in foundations, and even as a civil society. Like, for example, PS Kenya, we're always looking for grassroots organizations that we can collaborate with and work with, especially in areas where we are not very deep, like in rural areas or very remote areas. We work with community-based organizations because we know that these are the people who belong here. They understand the community best, and they are able to champion change at that particular level. So in addition to knowing people, friend-raising,
yes.
you
I've
also
now
need
it's
to
not
put
fundraising, it's friend-raising.
Yes, yeah. Is also putting your systems and structures in place. That you can get online from ChatGPT. AI is now working. Just Google, check. As a non-profit organization leader, what do I need to put in place for fundraising or to ensure? All that, the answers are there. So that's the easier part. The part where leaders and founders need to work on heavily is invest a lot of their time in getting the right networks and the right contacts and aligning themselves to what these particular organizations are doing. If you're well aligned, very good. If you're not, move fast, fail forward, fail quickly, so that you don't spend years trying to build this relationship, then it doesn't work. It's very frustrating. You're better off failing quickly and moving to the next and the next. And once you identify this is where, we are aligned with our mission, our vision with this organization, is again now investing in that relationship and being very patient, because it can even take 3-5 years before you see any results. Yeah.
I'm so impressed. So to the new founders network,
yes, network.
Fundraise as much as also you're fundraising, which is very keen. And this is the thing I tell people, we need also people like you to bring us to spaces or even show us the way on how things move. So as we are going to close there. What is your parting shots in terms of where is the future for your organization, yourself, and even Kenya in 1 minute?
Yeah. As I know we've spoken
you can dream bigger, you can
a
dream
lot.
whatever.
Yeah.
Utopia. Even within your own utopia world, where do you see the sector? Yeah. Even when it comes to SRHR or health. Yeah.
I think we must dream big of a country where every right is respected and rights on sexual and reproductive health are respected, that communities, women, men, are held with dignity. Girls have the agency to make the decisions that they want and really do that which they want as the young girls. So that would be my big dream for this country, and especially in sexual reproductive health. And also knowing nobody is coming to save us. The change begins with us. It begins with me. It begins with you who's listening. It begins with everybody. Therefore, let's lead. Let's collaborate with each other, even as we are working towards bringing this change together.
Thank you, Dr. Margaret Njenga. It was nice having a conversation with you. As we close this part 2 session of the Gender Equality and Human Rights podcast series, I affirm you, I celebrate you. Thank you for the work you do. For all of us, not only just for the institution population service, for us as Kenyans, really appreciate. Thank you.
Thank you.
That was Dr. Margaret Njenga, the Chief Executive Officer for Population Services. Watch out for the next episode of Gender Equality and Human Rights.